Welcome back to the second of our lecture series looking at the physiology surrounding cardiac resuscitation and how we can optimize our resuscitation using the physiological principles underpinning cardiac arrest. So we left off in our last lecture talking about the goals of care in cardiac arrest management and how we can use them as a way of determining the effectiveness of our resuscitation. I want you to reflect as we talk about this on whether you actually think about how compressions work, how performing chest compressions can get the heart to both fill and eject so that it ejects enough so that we are getting some blood flow to both the heart and the brain. There are a couple of elements to consider when performing chest compressions if we want to achieve those goals. So this is Tanya. She's 54 years old. She has put on some weight over recent years and has become less mobile now, requiring a total knee replacement, which she had 10 days ago. She smokes and requires inhalers, and in the workup to her surgery, they did a CTCA, which found that she had some coronary artery disease. Her husband heard a thump on the floor and found her in the bathroom. This is Andrew at the top right-hand side of the screen. He is 60 years old. He rides a bike every day, is tall, and is slender. He was nearing the end of a 12-kilometre bike ride on a summer's day where he was seen to come off his bike and was found unresponsive. Now, are these two patients going to respond in the exact same way to your treatment and resuscitation? Do you think that they have the same cause of their cardiac arrest? Now, if one of our goals is to achieve adequate cardiac output, then it follows that you want the area of your maximal compression to be sitting over the left ventricle. So you want to be pressing on the biggest part of the ventricle to ensure that you're actually getting stroke volume and forward flow. Pretty simple concept, right? And we're taught to perform the chest compressions in the lower half of the sternum, in the center of the chest, in the hopes that we are exactly doing that we're pressing on the left ventricle and we are squeezing it like a pump to try and achieve that stroke volume and forward flow. But we all know, that everyone's heart sits differently in the chest cavity. And this has been known for a very long time. It's well documented, well reported, and there's a lot of evidence surrounding this. There's multiple radiological studies in humans that demonstrate that up to 46 to 80% of patients actually don't have their left ventricle sitting consistently in that middle of the chest position that they talk about with CPR. So what is sitting in that position in the proportion of patients? It's actually the left ventricular outflow tract, or the aortic root. Now, you can see in this picture of the open chest that the aortic root is actually sitting right in the center of the chest, right where your hands are actually meant to be, or where we place our hands for CPR. And this is a real patient. Now, there is very weak evidence guiding the position of our hands during CPR, and that is well recognised by the Resuscitation Council guidelines as well. When they're providing these guidelines to us, the resuscitation councils need to tell us something. So they have taken the average and they've advised us to place our hands on the lower half of the sternum because in the average population, that is where the left ventricle is most likely going to be sitting, and it's the place where the least amount of harm can occur. Now, any lower down with your hands and you're compressing on the xiphisternum, which is not ideal. But what happens if you end up having to look after someone that is not in that average population? So those people where they do not have their left ventricle sitting in the center of their chest. Well, if those patients are in that position, the application of compressions actually runs the risk of completely obstructing the outflow tract of the heart. So that's the outflow tract, and the aorta is that large pipe that delivers blood flow from the heart to the brain and other vital organs. So if you obstruct this pipe, or if you obstruct this outflow tract, it essentially renders CPR ineffective from the outset. And it's not because compressions are being performed incorrectly. It is simply because all patients have different anatomy. These findings are now supported by increasing research studies, particularly looking at transesophageal echo, which are using it to locate the area of maximal compression. So there's data from a US toe registry with 500 patients, and that demonstrated that only 30% of patients had the area of maximal compression over the left ventricle. So essentially, the heart was not being compressed and there was no forward flow in up to 70% of those patients that were included in the registry. So this is a toe loop of the heart where compressions are actually occurring over the LVOT, and this toe loop was performed pre-hospital. You can see at the bottom of the screen the left ventricle, and that's not coming in and out at all. The thing that is being compressed or coming in and out rapidly is the aortic root or the left LVOT. We're one of the first pre-hospital services in the world. There are a couple of others, but not many, that are performing transesophageal echo in the pre-hospital environment. Now, they do it in the hospital environment when you bring patients in cardiac arrest. Some of these hospitals will place a transesophageal echo to assess compression effectiveness, but it's seldom done in the pre-hospital setting. And we're doing this at the moment as part of the pre-care research trial. Now, with this, we have the ability to assess very early on in the arrest where the patient's heart sits and help guide compression position in real time to ensure effective perfusion and intervene early in the resuscitation. Now, this is a toe loop of the heart once compressions are over the left ventricle, and you can see that it's coming in and out rapidly. So you know that if there's blood volume in that left ventricle, it's actually being ejected and you are getting stroke volume and forward flow. Now, what clinical changes did we see when we did this to the patient? Their colour improved. We could palpate a brachial pulse. The heart went from a PEA into a VF because the coronaries were now being oxygenated and the end tidal CO2 changed. So TOE provides the opportunity to guide compression position in real time and maximize forward flow in the early stages of cardiac arrest. It's more than likely that performing TOE in hospital is going to be too late. The time to intervene is going to be in the pre-hospital setting. But it's impractical to expect that TOE becomes standard in pre-hospital management in cardiac arrest. And this is research at the moment. It's not guideline based. So part of our research is understanding what tools we can give paramedics to ensure that they're delivering high quality perfusion with their compressions during the arrest and correlating that with what we're seeing on the echo when we do perform it. For me personally, an achievement far greater than instituting pre-hospital eCPR will be finding a way for paramedics to determine the effectiveness of compressions, making adjustments and changes as needed when we're not there with those advanced diagnostic tools. That would be game-changing. The pre-hospital use of TOE has provided this learning opportunity for paramedics as they can see the heart in real time and they can visually assess the effectiveness of their intervention. The concept of forward flow and compressions has become more concrete in this visual demonstration, and I think it's been one of the best tools that we've provided in real time to assist with this learning. So, what is the key message here? As I said from the start, the one thing I want you to take away from these talks is that every patient is different. The toe is a good example of the anatomical variance that can occur among some patients. What are you meant to do with this information, though, given that pre-hospital TOE is not performed at every arrest? As clinicians, we need to ensure continual assessment of clinical signs, those clinical signs that indicate that intricate dynamic between blood flow and the cardiac activity that you're invoking during your cardiac resuscitation. We want to assess that physiological response to the intervention because performing compressions is not simply a matter of setting and forgetting. Essentially, we need to be doing more than that. We need to be performing targeted CPR. We have CPR metric tools available to us that allow us to press or give us CPR feedback in order to get us to press harder and increase our compression depth. We have a metronome that's able to assist us with ensuring that we're achieving the right rate of compressions. So we have tools available to us to assess the rate, and the depth. But what do we have available to us to actually assess whether or not we are achieving a good stroke volume and forward flow? Because essentially, that is the end goal of this. That is what we want to achieve. Adequate depth of compressions, adequate rate of compressions is in the lead up to ensuring that you're getting adequate stroke volume and flow when you're performing your cardiac compressions. So end-tidal CO2 is thought of as a surrogate marker for pulmonary blood flow and cardiac output during CPR. The resuscitation guidelines all recommend its use to optimize your chest compressions. Early in the resuscitation, that end-tidal CO2 can be an indication of compression effectiveness. So when you get there and the end-tidal CO2 is low, the advice is to slightly modify your compressions. Increase the depth, change the operator, assess the change in end-tidal CO2. As the CPR quality improves, so does that number. Generally, end-tidal CO2 levels are higher in those patients who are achieving a ROSC or about to achieve a ROSC, and we all know that they tend to rise rapidly just before ROSC occurs. As the duration of the resuscitation increases, a persistently low end-tidal CO2, so something less than 10, is a reliable indicator that there's little perfusion occurring, and it is associated with a poor prognosis. But I must emphasize that the resuscitation guidelines do not recommend using end-tidal CO2 of less than 10 alone as a sole prognostic indicator. The trend of end-tidal CO2 is also important. There are multiple factors that can confound end-tidal CO2 levels, making the number difficult to interpret. Things like the type of airway can affect your end-tidal CO2. So a supraglottic airway, like the iGel, results in higher numbers because they do not clear CO2 as efficiently as a cuff tube. A period of hypoventilation before an airway is established may result in a high number. Pulmonary edema or pulmonary pathology can also result in an elevated number. And did you know that the administration of adrenaline can cause constriction of the pulmonary capillaries and transient decreases in end-tidal CO2? What else can we use to assess the effectiveness of our compressions, though? As I said, in addition to the CPR metrics that may be used to assess your compression depth and rate, you can put together a clinical picture to assess whether or not you are achieving forward flow with your compressions and whether or not your hands are over the left ventricle. So feeling for a brachial pulse with compressions ongoing may give an indication that effective forward flow is occurring. The brachial artery doesn't sit next to a vein, so its presence cannot be mistaken for a venous pulse. The reason why checking for a pulse was taken out of the guidelines a while ago is because people were feeling for femoral pulses, and they would feel the venous pulse and say, wait, stop, we've got a pulse, and CPR would stop, but they actually didn't. And so there was continuous interruptions to CPR, and we all know that one of the best quality markers of CPR is compression fraction and the fact that you are continuing to do compressions with minimal interruptions. So feeling for a brachial pulse means that you don't have to interrupt your compressions, and it's not falsely present or altered by a venous pulse. It can't be used as the sole determinant, though, in determining whether or not you're getting forward flow. It's just one of the signs. Other clinical features that we should be looking at include what the patient looks like. It sounds odd, I know, but we've all resuscitated patients that look more dead than others, and that's probably because they were getting less forward flow. You want to look at the patient's colour. Are they moving? Are they gasping? Do they look cyanotic? Is there some colour to their complexion? Do they have cypric? Like a little wobbly worm. It needs oxygen to stay in ventricular fibrillation. When we don't have any oxygen going to the heart or the coronaries, the heart will quickly go into an asystole or PEA. We've all seen that happen. So if you remain in a shockable rhythm, you know you are at least getting some forward flow and perfusion to the coronary arteries. Not a lot, and certainly not enough to get it restarted again, but you know you're on the right track. What about your SATS trace? Have you ever thought about putting a SATS probe onto a patient during cardiac arrest? It sounds a little bit crazy and not really high priority, but A good SATS trace, and even better if you have an oxygen SAT of over 85%, is a pretty good indication that you are getting some forward flow. So I think that we should be getting into the habit of placing SATs traces on SAT probes on patients routinely as part of the resuscitation and as part of our assessment. So these clinical signs form part of the clinical picture that can be used in the assessment of compressional effectiveness. No one measure should be used in isolation, but together it may be a reasonable indicator of whether or not you're achieving your goal of good cardiac output and adequate forward flow. That's the end of this lecture, and we're going to move on to lecture 3, which looks at perfusion and perfusion pressures and how we can utilise them to try and get a sustained ROS.